Year my mind wanders back to my first job as house surgeon at Broomfield Hospital, Chelmsford, halcyon days. In preparing for this talk, I was remembering what considerable variation there was in the length of stay after what we would now consider to be relatively routine operations. And I was remembering how Caroline, my fellow house surgeon, and I used to stand at the back of the ward round and slightly mischievously try to predict the discharge behaviour of our registrar. And I was remembering during the care of one young woman who'd had an elective cholecystectomy, how we identified a novel marker of recovery and were able to correlate that as a predictor of discharge. It's never been presented at a medical meeting, neither have we published or had a poster, so I thought this might be the ideal opportunity to present it to a healthcare forum. We noticed that we called it the lipstick sign. Mutter ye not. So the lipstick sign was because we noticed that this young woman, when she started to feel a bit better, would apply a layer of lipstick. The next day, she applied a thicker layer of lipstick, and it was at that point that our registrar would discharged her. We tested out this on some other young women and we noted a similar correlation, so we called this the lipstick sign. And we had a code in the notes. Yeah, I know, we did that sort of stuff back then. A bit like consultant smoking clinic. And we would write down lipstick 1+, when there was one layer. And then the next day, lipstick 2+ as an indicator of their lipstick status. Now, obviously, it's somewhat limited in terms of how we extrapolate that sign, particularly amongst the male contingent. But perhaps that was the beginning of my interest in criteria-led discharge. Most of my career since then has been dominated by three slightly more serious questions. Do they need admission? Do they still have medical needs that are best addressed in hospital? And is it safe to discharge them? Let's unpick those a little bit. Do they need admission? Is there any other way to meet their needs that doesn't involve them staying overnight in this hospital bed? With obviously the investigations, treatment and care involved. Sometimes it does feel like they're on a conveyor belt, and the more steps they take from ED, the acute medical unit, to the ward, the harder it becomes to stop that conveyor belt and push them off, point them in direction at home, because the more people who've said they need to go closer to a hospital bed, the harder it becomes to reverse that process. Of course, these days we've got many excellent methods for alternatives. Our ambulatory care unit, our virtual ward, hospital at home, and never have we had so many opportunities for getting them off that conveyor belt and getting them back home and doing things a bit differently. Secondly, do they still have medical needs that are best addressed by them being in hospital? Well, first of all, that of course means that we need to define what their medical needs are and the underlying discharge, the underlying disease processes, and that can of course take time. Part of that is also about assessing what the acuity of their needs are. And we use the news, the early warning score that gives us some guidance in that. And how we determine that will also be around gathering collateral information about what their normal baseline level is at. So we now able to see electronically in our hospital, and it gives us an opportunity to grade really what their overall physiological status is doing in terms of are their needs rapidly increasing, decreasing, static, etc. We may also need to agree expectations in terms of how further their needs will be met. And obviously now we use treatment escalation protocols and sometimes last days of life care plans as well. And then thirdly, is it safe to discharge them? What makes a discharge decision easier, difficult? Let's just pick through that a bit. So for me, the easier decisions are when it's a single condition. So one new acute medical condition that has provoked their discharge, and that's something that I can focus on. It's easier when they've got a well-defined recovery. And, day to day, there's a clear improvement. When they have no rehabilitation needs, obviously, it's simpler. When they're independent and they have no care needs when they go home. Oh, how I long to have a ward full of these sorts of patients. It's also very helpful when the patient and relative is keen for them to go home. I'm sure you've noticed that. Now you know what's coming. The harder decisions, the multiple conditions, where the precipitant is unclear, where their recovery is fluctuating from one day or from 1 week to the next, when their rehabilitation potential is unclear. They have complex care needs, and patients and relatives are risk averse or have unrealistic expectations. What about the doctors? What are their expectations? How do they see the risk? And we've heard already quite a bit about this today. And it's important that all of us, as healthcare providers, have some insight into where we lie on the risk scale. Are you a risk taker? I see a few of these. I drive down the A13 each day. They're the relaxed ones. They're perhaps under-aware that overtaking on the inside at 80 miles an hour is perhaps not conducive to a long and healthy life. And then there's the risk averse, those that are anxious, overly aware of the risks that surround them. Now, all of us lie on that spectrum. I've somewhat stereotypicalised them. And I think it's important that we have a variety of these risk temperaments on our team. We need risk takers. We need people who are ambitious. We also need people who are a bit risk averse. It's not helpful if we have those who are at the far end of the extreme, but a healthy dialogue results from that checking and challenging between those who are risk averse and those who are perhaps a bit more of the risk taker variety. We've heard also about how important it is to understand where the patient lies on that continuum as well, and recognise that our decision making, wherever it's possible, needs to be aligned with their own view and their own risk status. Patient safety is something that isn't absolute. As when I used to be clinical director, I heard this all the time. People tell me the hospital is not safe. I found that difficult as a concept, because that implies that there are times, therefore, when the hospital is safe. If it wasn't for the fact that there are times when the hospital is safe, people wouldn't need to come to me and tell me that the hospital is unsafe. But of course, this isn't a binary status for our hospitals, is it? And we need to think of how we can make patient safety not an absolute. And we need to be honest and open about this with our colleagues and with patients as well. And we need to think in terms of we would like them to be safe, and how can we make things safer than they are. Making things safer, as so eloquently demonstrated in the video about Doug, about embracing risk. I love that term. I have to think about how I'm going to use that at work. But for Doug, he was someone who was prepared to make things a little bit safer in order to help him to achieve a higher goal, to be at home for his birthday. The concept of safest is something also that we can't think of for one individual. We have to think about not only what's safest for this individual, but what's safest for the collective of our hospital community. Helping our consultants understand that there has to be some compromise between making things as safe as possible for their individual patient, and also take into account the ambulance queue outside of the hospital, where there may be a queue of patients who are considerably unsafer than their patient who's perhaps being discharged slightly earlier than they would have ideally liked. That's a difficult concept to communicate to colleagues sometimes. I'm preaching to the converted, but I thought I'd just show you how I address this with my colleagues. I ask this question: is being in hospital safer for our patients? Yes or no? It is, of course, a trick question. Yes, when they need constant nursing and medical care, it seems it's the right place for them. No one would argue with that. But it's not the safest place for them when the imposed inactivity, disruption to routine, the emotional deprivation, the familiological cognitive equilibrium of a frail patient. We've heard quite a bit about that already. And incidentally, we've heard quite a bit about the physical impact of deconditioning. It'd be great to hear more evidence of what the psychological impact might be. To what extent does deconditioning impact mental health as well? We've all seen it. Anecdotally, we can talk about it, but it would also be great to have some hard evidence. So I'm going to send Pete away. Pete Gordon, that's your homework for the next. I'll give you a month to work on that. 2 messages that have changed my practice. I can honestly say that these 2 things have changed the way I think about how I manage my inpatients. The first of which is from our palliative care team, who tell me that 1 in 3 of our acute medical patients are in the last year of their life. The second comes from our care of the elderly physicians. A prolonged hospital stay may shorten the life of an elderly, frail patient. Have you thought about whether there may be some cause or effect and what direction that's going in that? Is it perhaps the fact that they're in hospital that they're more likely to die in the next year of their life? What is the proportionate component of that? Another job here, Pete. So the way I like to express this is to say, being in hospital is good for our patients, is best, if you like, for our patients when we can capture that narrow window of opportunity to maximise the benefits and minimise the detrimental effects of a hospital admission. How do we do that? Well, we do like to be beside Southend on Sea, more accurately known as Southend on Mud. But our patients don't like to be in Southend Hospital. They tell me that all the time. And never do I see such happy patients than when I mention the D word. We had a perfect week, except we rebranded it as valuing our patients' time. And On Sunday, I was talking to a patient about how much waiting there is in hospital. The one patient that really sticks in my mind is when I said to him that because of his congestive cardiac failure, his life was likely to be limited, and we needed to treat him with intravenous diuretics in hospital. It might take quite a while. His response was quite unexpected. He said, "I haven't got time. I'm a model boat builder, and I have a number of orders that I have to complete. And I'm very keen that if I am coming towards the end of my life, that I complete them all." And one of them was for a royal as well. So, to much similar to the stories we've heard earlier on, finding out what's important to the patient is really, really key to make sure that our agenda and their agenda aren't completely at odds. So we had this week of perfection in February, and we had two objectives. The first was to reduce the number of patients staying for 14 days or more, and we applied the tools that have been described earlier. And the second was to ensure that every patient had a comprehensive clinical criteria for discharge documented in their notes. This was a medical directorate thing, but we hoped the ripples of greatness would spread out across the trust. So what did we find? Well, the first objective went quite well. The Wednesday reviews, we were praised for our, I wasn't, but my colleagues were praised for their innovative practice in this, and indeed we saw the 14-day stayer numbers come down. Maintaining progress since then has been a bit of a challenge, as it is often the way. Number two challenge, the CCD one. What we found by sending lots of spies onto the wards, sorry, not spies, what are they? Ward liaison officers, that's it. We generally found that the discharge criteria were not defined in the notes. We found that discharge criteria were not discussed on board rounds, so no ripples of greatness going on there. We did, however, find that people were generally good at planning for today. Not so much for tomorrow, but there were good plans for today. All that was all rather disappointing and discouraging, particularly as you might have thought from the various comments today that Southend is not quite the epicentre of CCD brilliance, as you might think. So, we got there. There we are. So here's some examples, because I realise that I need to start from where my colleagues are with this. So here, I don't know how well you can see there, but this patient with an infective exacerbation of COPD, and there's a good plan in consultant's handwriting there, and the bottom line there is home when off O2. Okay? So you could pick that out as a clinical criteria for discharge. I can pick it out, perhaps not quite so easy for nursing staff to pick out that that's what is implied there, and not necessarily framed in such a way that would enable criteria-led discharge, i.e. a discharge decision to be made by a non-consultant or even a nurse. Here's another example. The bottom line here is home if, I like that, good start, home if off oxygen and NG tube out. There's a little bit of stuff up here that is perhaps slightly contradictory, because it says we need a neurology review and a gastroenterology review, so perhaps it's not quite clear. And our speech and language therapist is going to remove the NG tube. It might have been news to them, but I might be wrong. So, again, there's a bit of a lack of clarity there, although, you can see some good thinking there. How about this one? Again, if CT head normal, medically fit, and then chest X-ray pending. Okay, so again, we need to know is how important is that chest x-ray to be done now, today, while they're in hospital, or could they come back another day and have that done? Needs a bit of explanation. Now, I want to talk to you about how we need to tune our ears into hearing the sound of a can being kicked down the road. Now, the reason it's really important to have those skills is that I would imagine many in this room are asked in times of crisis. It feels like black is no longer a crisis anymore, because what really matters is the internal critical incident, and an email will pop up talking about challenge rounds. Is it just Southend or others challenge rounds? Yeah, okay. So sometimes I'm facetious and say, what do we mean by a challenge round? To me, a challenge round, perhaps the most useful thing that can be done, is having a dialogue to determine, is everybody agreed that this patient isn't ready to be discharged yet? And is everybody agreed at what the criteria are for when they would be discharged? And this is really, really helpful for consultants, because they don't like being asked to do an extra ward round because we're in black or in critical incident, because they would like to think that the decisions that they have made are still the same decisions. Now, that's very much dependent on whether they have made decisions just for today or yesterday or the day before when they did their ward rounds, or whether they've done some advanced planning. So let me explain what I mean there. So these are some of the terms that when we read in the notes tells us that the doctor doesn't know what's going on. Did I say that? Home when stable. Home when mobile. Stable and mobile. Discharge when back to baseline. Start discharge planning. Yeah, you've all read this. These are the things doctors write in the notes when they don't know what to do. Okay? And I think if we can identify these as a cry for help, then we'll know where to move to quickly, particularly in times of crisis. Home after the weekend. Have you ever run your eye down the EDD column? Have you ever noticed how great Monday's going to be for discharging, and how quiet Sunday's going to be for discharging? Because they've got to come and make a decision. And here's the greatest one. Yeah. Recheck the bloods tomorrow. Here is the greatest can or bottle being kicked down the road. Because when we don't know what to do, we check things again, just to be sure that we still don't know what we're doing. So here's a couple more examples, and you'll be relieved to know that my colleagues don't know that I'm ridiculing them. How about this one? Home tomorrow, if remains well. This is my ultimate favourite. I'd like that on my gravestone. Beautiful. How about continued current management? Now, if you really want to help our junior doctors who have to do a lot of writing, how about getting them a rubber ink stamp that says continue current management on it? That would save them a lot of time and ink. How about aim a home soon? How could you disagree with that one? And mobilise. I did have a patient once when I worked in ED. I said to them, we're going to give you some antibiotic tablets and then we're going to send you home. He said to me, I don't think I could walk that far. How about fit for discharge on Thursday? Thursday's a magical day. There's an inherent healing in the waters on a Thursday. And then there's a bit more confusion because they've written arrange for rehab, although the writing's starting to go a bit astray. And they've crossed it out and said, oh, RFD. So what we introduced was a criteria-led discharge sticker. To make it really, really obvious and to provide a framework there to enable us doctors to write clearly and to focus our minds. So this says that if the following clinical criteria are met, the patient can be safely discharged without further medical review required. This, of course, is something that perhaps a junior doctor can also discharge on the basis of as well. And there's criteria, up to 4, with the name of the doctor down there. So we produced this sticker, and it's too big, and it doesn't fit terribly well in the notes. But what we do ask is that all colleagues use this on a Friday. We've recognised that because patients are having reviews Monday to Friday, and we were getting some kickback on it anyway, people preferring just to write in the notes, that at least if we had this in the notes for a weekend when most patients aren't getting a senior review, that it'd be very clear there what the basis for the discharging that patient is, and ideally the nursing staff might be able to make those decisions. So, here's what they look like when they work well. So number 1 here, criteria, creatinine less than 100. Number 2, an ultrasound, the kidneys, ureters and bladder with no new stones. And number 3, oxygen sats on room air. I guess that means normal, within range. So the criteria-led discharge provides a lot of good things. Provides purpose to the patient. I find that patients respond very well when you say, not now, but this is when. Okay, it gives them a certain expectation, something to look forward to, if you like, rather than aimless waiting. Some expectations to the relatives, and sometimes talking to them about what would make us ready to discharge also creates the opportunity for a conversation around what their expectations are. So in other words, rather than waiting to that point of saying, we're discharging them now, and then saying, oh, but I thought that, this is an opportunity to have had that conversation with the relatives. Okay, I know you're expecting, such and such before they go home, but let's just talk about why that's something that we don't think is realistic, appropriate, achievable, etc. Thirdly, it provides some consistency. Our a multidisciplinary team, nurses, rehab team, pharmacists, social worker, they hate the erratic nature of some of the decision making. They want to be able to plan ahead. And having some criteria, knowing what's in our minds, gives them just a sort of rough idea of when it might be that they can expect to need to do certain tasks as part of the discharge process. Number 4, it provides communication from the consultant, and not just on days when they're doing a ward round. I think if these clinical criteria are there in the notes, then our junior doctors know, and they can talk about it on the board rounds, what the consultant's ambition is. It gives them confidence. One of the hardest things we learn to do as junior doctors is discharging patients. And I think being able to learn from a senior doctor on how to set those realistic goals and targets is a great thing, as is being able to discharge a patient confident that this is exactly when your consultant would discharge them. It's a partnership with the nurse. Great quote earlier on that's probably somewhere on the floor now about the importance of Jyoti gave us about team and trust. Really important. And I do think that the criteria-led discharge does both depend on trust but also build trust between doctors and nurses. And finally, well, you can decide what level of importance this is, but certainly assurance for the trust is something that we want to be able to provide. Let's talk then. I've got 10 points to make then about some of the barriers that I've noticed to criteria-led discharge. So, number one, we've not yet figured out why the patient was admitted. It can be quite difficult to identify criteria for discharge if you've not yet identified the criteria for admission. And that sounds funny, but it sometimes takes a bit of time, particularly for complex medical patients. And I'm afraid often the patients are no help whatsoever. Sometimes the first line of a medical clerking is patient doesn't know why they're here. Well, that's not a great start, is it? And they're not necessarily the cognitively impaired ones, by the way, as well. And it's at times like this that I find it's invaluable to just go back a step. Talking to family, looking at the GP letters, or even phoning the GP, looking at the ambulance records, which I have to say, embarrassingly, is sometimes better and more detailed than some of our medical clerkings as well. And now that they're usually printed, and you can read the paramedics' handwriting, they're gold dust, providing nuggets of information, particularly in the frail elderly. Comments about the environment that they've picked them up from, for instance, and their observations there. So that's number one. Number two barrier. Doctors think that they're already doing clinical criteria for discharge. And you'll see from some of the notes there that I've showed you that they do show some evidence for some forward planning. But it does need to be made more explicit. For some, it's just don't tie me up in red tape. Don't give me another 3-letter acronym to have to grapple with. I've got enough of them. But also, I just wonder whether this is a defence for a paternalistic culture as well, whereby I'm a consultant, I decide when the patient's ready for discharge, and I'll know, trust me, I'll know when they are. And I think for those who do tend towards that approach, that means that they're not given an opportunity to air what they see as being the criteria for discharge, and therefore no one can challenge that. And therefore often when the consultant does decide that they're ready for discharge, then they may find themselves on a collision course. They may, of course, find themselves on a collision course a week before that, when everyone else is crying out for them to discharge the patient. So I think it's really important that consultants talk about what they're thinking. And this brings me to barrier number 3, that I think everybody can hear what I'm thinking. Now, give us the benefit of the doubt. We do need thinking time, and we don't get a lot of thinking time. And when we're on a ward round and we're faced with having to collate very quickly lots of different bits of information from lots of different sources, it can be difficult sometimes to synthesise them, particularly for those like me who are not multitaskers. But when I walk away from the bedside, I need my junior doctors to challenge me and said, what were you thinking there, Dr. Day? What's the plan there? I can hear myself thinking, and when I assume that others can hear what I'm thinking, it means stuff doesn't get written down. Just to explain, my junior doctors write down the notes for me to save time, but it's essential that they know what the plan is, and particularly their clinical criteria for discharge. Number 5, we prefer to discharge patients in better shape than when they came in. Yes? Here's a quote from Rob George. He's a consultant in palliative medicine, very experienced physician. And he said, "I'm not afraid of the truth. General clinicians seldom achieve cure. We manage deterioration and dying." So if at work tomorrow I were to ask my F1 doctor, who just started a week ago, "Why did you come into medicine?" I would expect her to say something along the lines of, well, I wanted to make people very surprised if she said people's deterioration. Maybe we need to talk about that more with our colleagues and recognise that we are sometimes failures and we need to get over that, and we need to recognise and acknowledge what our role often is, particularly in general medicine. Number 6, our patients in Southend are... No, stop there. Our patients in Southend are more complicated. Fact. Okay. I've spoken to a number of audiences, and everybody thinks their patients are more complicated. And you all have your own idiosyncratic reasons for that. It's because we're on the coast. People come to the coast to be more complicated. It's because we're in rural areas. People don't have mobile phones or broadband, therefore they're more complicated. Okay? I'm afraid I've got bad news. They're all more complicated everywhere now. Number 7, when it comes to setting clinical criteria, they're often not specific enough. An example there already. How ambiguous are they? They need to be as specific as possible, ideally with a number measured to them. Stable to one person means a very different thing to another person. They need to be achievable, and baseline is not achievable. We haven't got long enough. I'm not going to live long enough for them to regain their baseline, let alone them. It needs to be relevant, it needs to be realistic, and that does mean understanding more about our patient and you know, the Liz Sargent question, how were they 2 weeks before they came into hospital? You know, it may well be that their daughter wants them to be able to take the grandchildren to Disneyland, but if they weren't getting out to the spa, then what hope have they got of that? We need to know. It needs to be time bound. Now that's quite difficult, but I do think that we do need to set ourselves some sort of time. Mischievously, I like to interpret Liz Sargent's assertion that all but the critically care-admitted patients, we ought to be able to sort them out in 14 days. You know, maybe we do need a time limit. You know, the clock's ticking, Mrs. Jones. Been here 13 days. Still got your NG tube in. But you know, I think having some sort of you know, we've now got the length of stay on our board, and I think it does focus the mind to a certain extent. Really? Have we really taken this long so far? And really to reflect a bit on whether the time that we're taking is appropriate. Okay, so here's some examples then of what I mean by SMART criteria. So, AKI stands for acute kidney injury. It's a common problem, particularly when patients are admitted with dehydration, acute infection, or some other insult as well. And so you might see in the notes there, fit for discharge, medically fit when the AKI is recovered. Okay, so to convert that into SMART CCD, that would be in less than 125, not baseline. I've got a rule of thumb, nobody has shouted me down, or at least no nephrologist has shouted me down, and that's, roughly speaking, if their baseline creatinine is 100, how about we aim for within 25% of that? In fact, the trend is also important as well. So there we see an example. If renal function is at baseline, then MFD. So we need to be able to encourage our doctors to be more specific and be more realistic about it. Secondly, perhaps a gastrointestinal bleed. A rather vague one might be although it is a start, there's no evidence of further upper GI bleeding. That's what we want to say. But how do we break that down in terms of specific criteria that would give us that necessary reassurance? And here's a nice one from a consultant gastroenterology colleague who's done that. And there's some elements that we might use to break that down. Pneumonia. Doctors will sometimes put they can go home when they're off the intravenous antibiotics. What's the question we want to ask? When are they going to be off the intravenous antibiotics? What are the criteria that we need? And so we might say, okay, they've got a normal temperature for 24 hours. Their neutrophil count was less than it was at admission. To me, if it's less, it's getting better. I don't need it back to normal. And they're not requiring oxygen for 6 hours, perhaps. These aren't sort of things that I would be dogmatic about. It's about providing reassurance. And other consultants may express things in a different way, either more risky, they can take the oxygen home with them, or perhaps more risk averse. But at least everybody knows. At least it's out of their heads and onto the paper there, and open for discussion, for check and challenge. Yates barrier. Us doctors do often muddle up our clinical goals with the rehab and care goals. Now, I know that the NHSI CCD document says that CCD needs to be framed in terms of the physiological and the functional elements of this. Well, at Southend, we've taken a decision to break that down slightly, make the doctors responsible for the physiological elements of that, and the rehab staff, the functional elements of that. It's not a hard and fast thing. There is blurring between it, and Pete tells me off every time, in a nice way. But it is something that I would like to have a meeting of minds with our rehab staff, so that we have a more unified and consistent approach in it. But from my experience, often doctors won't focus on the clinical medical criteria because, well, they can't walk anyway, so that's going to take a while, and they're not well enough to go home, or they can't go home because they're homeless, or because they want to go into a nursing home, or whatever. So I think sometimes doctors' decision-making can hide behind some of the rehab and care issues. And I say to my doctors, we've got experts here. Don't tell them how to do their job. Let them do it. Let's focus on what we need to do, and let them address those aspects. Now, there are some situations, example, where pain is impacting on their function. That I might have a criteria and say that they're medically fit for discharge when their pain is sufficiently controlled to allow them to walk to the toilet. Somebody with COPD might have a similar one, that their breathlessness has improved to the point that they're able to wash themselves without difficulty, something like that. But what I want to avoid is us doctors saying, aim for discharge once rehab fit for discharge. Number 9, this is another challenge that we've certainly nowhere near cracked yet. Our nurses lack confidence in this criteria-led discharge process. So we've got this form here that basically says to the nurses, when you have identified that the creatinine is less than 97 and the temperature's been normal for 24 hours, you can discharge them. I recently had a conversation, in fact I had a conversation even this last weekend, and the nurse said to me, okay, Dr. Day, this patient's temperature's been normal for 24 hours, their creatinine is less than 97, and there was another criteria as well. Are they medically fit for discharge? Okay, well, what are the clinical criteria for discharge? She went through them all again. So I said, yes, you're telling me that because they've met their clinical criteria for discharge, they're medically fit for discharge. And she said, so could you write that in the notes, please? Okay. I talked about this a little while back. I'd had a similar conversation the week before, and I said to the audience, it might even have been this particular CCD, and I said to the audience, it was great. I explained things to the nurse, and she was reassured. And she discharged the patient, because I checked the next day, she discharged the patient without a doctor needing to come and see the patient. One of our junior doctors came up to me at the end of the lecture and said, by the way, Dr. Day, I thought you might be interested to know that after the nurse had that conversation with you, she called me to come and write MFD in the notes. Okay, all right. Hearts and minds and trust. And I and our nursing director continue to have a conversation about how we do build confidence in this, and whether there needs to be something as formal as a competency framework or just a simple basic SOP that makes the nurses feel confident and protected in this role. Perhaps something that we can talk more about during discussion time. So this is from Liz Deutsch's excellent document on implementing nurse-led discharge. So this is an NHS improvement document based on her research. And just a very nice graph there, talking about the 3 elements for criteria-led discharge, including the staff training of it. You know, and I guess we have to accept that we've not done enough of that. We've focused very much on training the doctors and not yet on the nursing staff. Number 10, the doctors lack confidence in follow-up arrangements. Something I've been aware of for a while. When I see some of the reasons and talk to doctors about the reasons why they don't want to discharge patients, it makes me realise how unaware we are of life outside of hospital. So a lot of changes have taken place since I was a medical student and since I was a junior doctor in terms of ways of managing chronic conditions outside of hospital. And as Pete referred to earlier on, his colleague who calls him a loser. I know, I was thinking the same. You know, for just, you know, us not really realising that we have patients in our hospital beds that they're managing all the time, and even, you know, those with greater demands in their own home. So there's clearly a gulf to be bridged there. So we're holding an event next month. Instead of our regular medical grand round teaching session, we're going to do things a bit differently, and this is my plan anyway. We're inviting a number of our discharge coordinators, experts and community partners, our hospital at home team, our dementia intervention support team, district nurse, community matrons, rehab, to come along and act as a panel, and I'm going to present 3, maybe 4 cases, and ask the question: how could you, or how did you support this patient when they went home? And in what ways can we learn from this in terms of perhaps expediting sooner discharge? So I'll probably tell you about a year at a time whether it worked or not, but what I'm trying to do is to make us less hospital-centric, if you like, and more aware of just what can be done in the community in terms of care of patients that we assume needs to be admitted to hospital and can't be discharged from hospital. And I hope as a result it will build up confidence. More and more our junior doctors are having to do, in fact all of our foundation trainees now have to spend a certain proportion of their time in some sort of community role. So perhaps this is primarily going to be directed towards the dinosaurs like me. Barrier number 11. Oh, got 11 now. There's one extra every year. This was our lovely sticker. So one day I was going around the wards just to see how things are going, and I said, went to the ward manager on one ward and said, well, how's clinical criteria for discharge going? And she said, oh no, we're not doing it at the moment. I said, oh, why is that? Is this some sort of fundamental disapproval of the whole scheme? No, we've run out of stickers. I think probably this principle can be extended to other forms where we have lovely tools. We've talked about many of them today, and just the importance of making sure that they are tools and that we master the tools and the tools don't master us, and the importance of communicating to my colleagues that actually that CCD and CLD are so much more than just the sticker. The sticker had come to be synonymous with the process. And actually that's one of the reasons why we've said just make sure there's a sticker at least in the notes on a Friday. I'm sometimes asked this question, should all patients have a clinical criteria for discharge? It may not be possible, may not be appropriate for everyone, and I shy away a little bit from being overly dogmatic about it, lest that becomes a reason not to do CCDs on anyone. So for instance, in the very early stages of admission, I recognise that it may not be possible to have really got to grips with the reason why someone's in hospital. We may not have sufficient information from the investigations. And secondly, they may also be very unwell. And when someone's very unwell, sometimes it can be quite difficult to conceive of them being well enough to be discharged. But I do think that's what we need to move towards. Patients on a last days of life plan, and where their hospital is the preferred place of death, is another example, of course, where they wouldn't have a CCD. But these are exceptional cases, a small proportion. And it was interesting from data, can't remember who it was presented this earlier on, but in the length of stay reviews, the predominant reason or category for patients in hospital more than 21 days was those who had a new score of less than 4 and didn't have a clear plan. Other reasons why patients are kept in, repeat bloods. We've talked a bit about that. I try and encourage junior doctors and say, well, actually, we could give them the blood form to take away and have it done another day. I try and dissuade them from telling the GPs, unless we tell them clearly what the plan and the criteria are. This is another one, INR, to be in normal range patients who are anticoagulated. So there are patients out there attending the anticoagulation clinic who have very prolonged INRs, and they manage them on an outpatient basis, so don't keep them in for longer. Investigations, we have a method for expediting our imaging requests to get them done within a week, but of course we need a method for looking out for the results. So what we do is we put the patient, keep them on our ward list, but we put them down at the bottom as a virtual patient to prompt us to. I could add in on to this bowels. Thank you for that mention about bowels. I wonder how many patients there are in the UK at the moment in hospital because those bowels just ain't moving. And that's certainly something worthy of challenge. As is potassiums. Potassium. In fact, we can keep people in hospital for magnesiums these days as well. It's fantastic, and I hope we'll have more reasons to find to keep them in because they're whatever isn't quite within range. And it is very difficult sometimes to debate this with colleagues because we know that it's bad to have a very low or a very high potassium, but what if it's only just outside the normal range? And just needing to see that within the context, particularly of someone for whom it's not going to make a jot of difference to their quality or quantity of life. Staying in for specialist opinions, another one. Okay, so I'd also like to highlight, got a bit of time still, the second review of the day. So I think we're at the point now where we can have a consultant review for all inpatients twice a day. It could happen. Now, I know what you're thinking. How do we sell that one? You can't see your children tonight. You're moving to 2 ward rounds a day. I know you've only just finished your first one. It's 4:30. Now, I might be being a bit controversial here. But what I'm talking about is that a consultant review of a patient does not need to be face-to-face every day, twice a day. But that doesn't mean that we can't add a senior review for all of our patients twice a day. So our routine is 9:15 in the morning, we do a whiteboard round, we talk through the plans for all the patients, we identify those who need a TTA now, we identify those who overnight have achieved their clinical criteria for discharge, and therefore we don't need to go and see them in order to start getting things moving. We obviously liaise with our multidisciplinary colleagues as well. We do our ward round. We update the nursing staff on decisions made on the ward round. At 4 o'clock in the afternoon, together, we talk through them all again, just with the senior nurse and sometimes our discharge facilitator. We talk through them all again. An update on what we've done. Number one, did we do what we said we would do today? Have we checked the new results reports, specialities, opinions? Now, I do find that sometimes it's not just about having a senior person grilling the junior doctors about things. It's just having someone to prompt and facilitate that review of how do we do with our plan. Has the patient now met their CCD? They didn't this morning. We were waiting for a blood result to come back. Okay, great. The haemoglobin hasn't dropped any further. They're medically fit for discharge now, and so on. I found that this really, really important, and often making the difference between a patient being discharged that evening versus being sometimes the golden patient the next morning. The golden patient is sometimes a little bit tarnished if when you look at that they could actually have gone the day before, by the way. But also I think even if the patient can't go home that evening, I think it does give you, it does mean that we can at least be making sure that perhaps care can be restarted in anticipation of them going home tomorrow. Interested to hear what people think about that concept. And by the way, I work with closely with other consultants, and we have 2 slightly separate teams, but I review their patients as well in that process. When I say review it, it's about even I don't need to know the patients particularly well. I can just say, what is the clinical criteria for discharge? Sometimes that's all I need to know in order to be able to have a conversation about our progress. Are the tests and the treatments we've done today targeted towards achieving those criteria? That's all I've got to say, except that I was really delighted to see the new the strapline, why not home, why not today? That certainly resonates with everything that I'm talking about, and to me it has the potential to reboot that default position that we're in, from why discharge the patient to why not. It suggests that a justification is required when we deviate from home as the destination. A justification is required by specific clinical criteria which describe the why and create a realistic expectation of the when. Thank you very much.